Hi, welcome to Chapter 1. This is Barbara Garcia, one of your instructors for pathophysiology. All right, so one of the ideas that we want to talk about is what is pathophysiology, right? So pathophysiology is basically the understanding of the pathology or what goes wrong with, and then our physiology, right? So we want to make sure that we understand that we're not going to be talking about physiology much. We're going to be talking about the patho component. The patho component is what goes wrong with our physiology. So basically, right, remember physiology is very based on homeostasis, right? So homeostasis is a very important concept for you to understand. What is the normal mechanisms that maintain that stable internal environment? Now, in patho, we're going to be talking about how that basically gets disrupted. Okay, so it's disrupting that normal. And when you disrupt that normal homeostasis, that's basically called disease. Okay, so right, so obviously our framework is an understanding of diseases, right, and how they affect human beings. So we're going to be talking a little bit on how that is going to be seen in and manifested in humans. So first of all, one of the very important topics that you want to learn about is etiology. Etiology is going to be something you're going to see throughout your entire nursing career. Etiology is basically, well, what is the cause for this pathophysiology? It could be genetic. It could be autoimmune. You need to be able to understand what is the basis for that pathology or pathophysiology. Then pathogenesis is going to be the course of the disease. Like, so is this disease going to be very virulent, or is it going to be rather minor, or is it going to be acute versus chronic, right? So clinical manifestations, as the name kind of implies, you're going to see what are the signs and symptoms that you're going to find, right? What are the visible characteristics of this disease and what are the non-visible, right? So signs are visible and symptoms are non-visible. And then obviously the treatment and implications of treatment, which could mean that somebody gets a disease from the treatment. That's very possible. And we're going to discuss that. Okay, so etiology, right? So what is the cause for that particular disease? Again, say, multiple sclerosis. So multiple sclerosis is going to be a pathology or pathophysiology that's going to cause breakdown of the myelin sheath that surrounds the axons, particularly in the central nervous system. So what is going to be the reason for that? Well, the reason why it starts to break down is because it's autoimmune, right? So that is the etiology. Okay, so what provokes a particular disease? So let's say that you're talking about and interestingly enough, alpha-1 antitrypsin deficiency, right? That is basically genetic emphysema. Genetic emphysema is actually going to be obviously from a genetic etiology. So people who have these particular different alleles, right, they are going to manifest the disorder. All right, so etiology can also be defined as an unknown etiology. We call that idiopathic. So that means that we have no idea where this came from. Or it could be as a result of medical treatment. We call that iatrogenic. You'll see a lot of people get leukemia as a result of chemotherapy. All right, so chemotherapy was trying to kill your cancer, but it affected your red bone marrow, and now you have leukemia. Right, a risk factor is something that is present and increases the likelihood of a disease. Let's say that you have a particular disease that is much higher in women, like multiple sclerosis, than men. So that being a female is a risk factor. Sometimes your background or your ethnicity might also be a risk factor, but also could be, some other likelihood that's going to make you more prone to getting this disease. Right, so pathogenesis, right? So the development or evolution of the disease, right? So the evolution of the disease, the ultimate expression of the disease, right? So this is a really important, again, Something you're going to see a lot of times in nursing, when you do your, clinical report, you're going to see the words etiology, you're going to see pathogenesis, and you need to be able to describe that disease and the manifestations of that disease and the development of that disease. Okay. So again, I mentioned the manifestations being signs, symptoms, right? So signs are objective or observed. So if I were to tell you headache, is headache a sign or a symptom? I can't see a headache. So obviously a headache is a symptom. Just like you can't see pain. So how do we make patients give us an understanding of their level of pain? We have them give us a 1 to 10. And obviously a 1 to 10 is going to be very subjective for every patient. And so some patients will be like, it's a 10, it's a 10, it's a 10. And so you assume, obviously, by the fact that they rated there because you don't see their pain, that's a symptom. You have to then give them medication that might be according to the pain that they say they have. Whether or not they do actually have it is not something we will ever really know. All right. So that, of course, can lead to, abuse of certain medications. Now, a syndrome is a collection of signs and symptoms, right? A collection of signs and symptoms. And some syndromes have a list of signs and symptoms that you are going to be very commonly going to see in a particular disorder. And sometimes you have a syndrome and it's something that has not yet been determined. Okay, so a collection of signs and symptoms is called a syndrome. Right, so a good question, which of the following is an example of a clinical manifestation known as a sign? Nausea, bruise, headache, or loss of appetite. So obviously nausea, not something that we can see. Headache, again, not something you can see. Loss of appetite, not something you can see. So that one is definitely going to be a bruise. That's something visible, a visible sign. So we know that this is something that we can objectively see. It is not subjective. Remember, the word objective means you could see it and you can evaluate it. I can evaluate it as a clinician. You can evaluate it as even a student, but you cannot evaluate a headache based on what you see. You have to ask the patient, what is it that they're feeling? And you can try to get an understanding of what's going on by the questions that you ask. All right. So the latent period. So clinical course of diseases are going to involve certain stages. So let's say that you got herpes, okay, as an example. So if you got herpes, then you're going to have a particular point in time in which you've been infected with the disease, but that you have no signs or symptoms. Why? Because it's the time in which the virus is basically going through and finding new cells in order to replicate. So then you're going to have a prodromal period where signs and symptoms begin to appear. Perhaps you're going to have a sore that starts to appear. Then you'll have the acute phase, in which the disease reaches its full intensity. So a prodromal period might be like say cold sore, right? Cold sore is starting to manifest, and then acute phase is where you see the complete effect of herpes. And herpes, upon initial infection, actually could be very flu-like symptoms. Okay, so you're going to see some very, very violent symptoms. It can be completely no signs, no symptoms. Okay, then the latent period can also, right, be when the signs and symptoms become mild or silent. Or subclinical is when the patient is functioning normally, but the disease processes are in there and very well established. Then you can have then a chronic clinical course, which may last months to years. So in your initial herpes infection, you, again, very, very much similar to like a flu virus, high fever, but then you probably will never get that again. Then the only manifestations you will see after that in the chronic, might be like a cold sore. Okay. So in acute, right, might be short-lived, right? But can have a severe manifestation. All right. Now, certain diseases have, an increase in the severity of disease and then a decrease in the severity of disease. Many of these types of pathologies are going to kind of have almost a cyclical nature. Like A lot of autoimmune disorders are very cyclical in nature. You'll see an exacerbation where the signs and symptoms are very severe, like lupus. Same thing with multiple sclerosis. They get very severe and then they just kind of go into remission and they decrease. So I don't know if you've ever heard, but a lot of women who have multiple sclerosis, who get pregnant, go into remission. And so they are almost free of the disease. And it makes them be like, oh my God, I wish I could be like this all of the time. Right? It could indicate the disease is cured if you are in remission, especially if it doesn't come back. An exacerbation also can be seen in things like sickle cell. So sickle cell, you're going to have like an exacerbation of disease, what we call like a crisis. And then it's going to go into remission and nothing's going to happen for a long time. Convalescence is a time right after the initial disease in which you are recovering, right? So, or a surgical procedure or something. So a lot of times people might be put into like a rehabilitation center or something for their convalescence, or sometimes a convalescent center because they are not, may not be able to come and return back to their original function. And sequelae are subsequent pathological conditions that can result from an illness. So further manifestations of disease that can be maybe indicating that the disease is still active, or other things that happen as a result of it, sequelae. All right, so understanding the etiology, pathogenesis, right, and clinical manifestations are very important in order to determine which treatments are the most useful. I don't want you to worry too much about medications and knowing each medication, but there are some medications that you absolutely need to already start looking at and knowing, because they are very closely related to how that particular system functions and how that physiology functions, and returning that physiology back to the most closely to normal function that we can. Especially things like blood pressure medications and other heart disease medications, and especially, blood pressure, again, very, very important. All right, so a little bit on some ideas on normality in health and disease. So a little bit about your epidemiology, maybe, right? And a little bit of statistics. So what is statistical normality? So I want you to go back to your statistics class and remember what a normal curve is. Yes, so your normal distribution, right? So the normal distribution is going to be a bell-shaped curve, right? Where the average is right down the middle. So let's say that you were talking about patients with diabetes, okay? So the normal mean for patients with diabetes, measured as the concentration of or amount of blood glucose in their blood, right? So that would be in milligrams per deciliter, is usually about 70. So that would be the normal mean for somebody who has who is free of the disease, okay? And I want you to remember that in one standard deviation, okay, so one standard deviation away from the mean is going to be, right, 65%, right? 65% are probably going to lie, values are going to lie within one standard deviation of the mean. Then two standard deviations of the mean, you're going to be 95, right? Percent. So this values right here are considered within two standard deviations of the mean. And that's a really important value. So what do they tell you when they look at your blood glucose levels? They're going to tell you that anywhere between like 60 and 100 are going to be, or 70 and 100 is going to be normal. So we don't want your blood sugar to be too low, because then you're hypoglycemic, but you don't want it to be too high, because then that can indicate that you have diabetes. However, notice that there are people who could be and have very high blood sugar who have not been diagnosed as diabetic. Okay, so this is the normal curve. So this purple one stands for the normal curve. Okay, and then those with disease, right? So when do you have disease? So at the point in which you might get a diagnosis for disease is if your blood sugar is going to be over 100, probably 120. So let's say the mean of those people with diabetes would be 120. So this would be 120. Let's just say this might be over 110. So over here and over here, right? Remember, those are people who are above or 3 standard deviations away from the mean or greater, right? So those are going to be 3 standard deviations, remember, is your 99.1, right? And so those are your normal distribution, right? 60, 95, 99.1. Mean, and those with disease, notice that it can overlap. There could be some overlap in those that have disease, because there could be people who have a very low blood sugar but still be diagnosed as diabetic. And so they may be low, but the average is going to be about 120 milligrams per deciliter. And then you're going to see that obviously it could be very, very high. Right? So statistical normality, right, estimates diseases in a normal population, right, based on our regular bell-shaped curve. So you have to remember the bell-shaped curve. So go back to statistics and review that, right? And the reliability is a test's ability to give you that same results in repeated measurements. So, you know, for diabetes, we're going to measure a few things, right? You can measure blood glucose. You could measure hemoglobin A1C, and you could measure things like the oral glucose tolerance test. So all of these are 3 different tests that we could use to let us know what's going on in a person's blood sugar. All right, so then there's another word that we want to look at, right? The word reliability versus validity. Okay, so this is a really important concept, right? If you have a clock like I have in my office, if anybody wants to stop by, my clock does not have a battery that works right now. Now, the question becomes, is this reliable and valid? Okay, so validity is the degree to which a measurement reflects the true value of what it intends to measure. Is this valid? No. Is it reliable? It's reliable 2 times out of the day. It's reliable, but it's not valid. So you have to make sure that you understand the difference between reliability and validity. Then we're also going to look at things like predictive values. So a test, okay, can it tell you the difference between a person who has the disease and a person who doesn't? And this is really something that you want to explore, because the ability of a test to be able to tell you whether or not somebody has a disease is extremely important. Just like, say, HIV. What do you have to do to HIV, right? How do we test this? In order for you to be able to know that a person truly has HIV. And let's think about the importance of that. If a person is out there who has the disease, but a test says that they don't, then this is a problem, okay? This is a problem. So then this is where our tests are going to be yielding 2 types of measurements. We're going to look at sensitivity, the probability that a test will be positive when applied to a person with a particular condition. And then specificity is the probability that a test will be negative when applied to a person without a particular condition, right? So sensitivity is basically used to rule out disease, because if you get a test with high sensitivity, then that person that gets a positive test has that disorder, most likely, depending on the sensitivity of the tests. Test might be 92 to 95, 99% sensitive. But if you have a test that's high in sensitivity, it's probably not going to be very high in specificity. So we have tests for HIV that are very highly sensitive, the first one you take. So sometimes people will test positive for that initial, like, rapid test for HIV, because we need the sensitivity to be very high, right? So sometimes you'll get things like false positives. But we would rather get some false positives, but every single person that has HIV test positive, than have, a 92% sensitivity, and then there's a bunch of people that didn't test positive and are out there spreading HIV. All right, so specificity. specificities tell us that the test is truly negative. Okay, that the person is truly a true negative. That means that they do not have the disease. So we follow up like the rapid test for HIV with like an ELISA test. And an ELISA test is going to help you rule in disease. So sensitivity helps you rule out disease, because if the person has the disease and the person becomes negative, then you can rule, you rule out that disease because they clearly don't have it, especially in a test that's highly sensitive. And so it's the opposite is true for specificity. You can rule in the disease if somebody with if the test with very high specificity, if they test negative, right, or positive with this very high specific test, then you're going to see that they probably have that disease. Okay, because it's high specificity means that if it's negative, they are truly negative. All right, so then other things on health and disease, right? So each culture defines health and illness in a manner that reflects their experience. So many of us are of some Latin or Hispanic culture, and so we have to be very sensitive of that, because not everybody has the same values that we do. Not everybody defines health and illness in the same way. So you want to make sure that you are very culturally sensitive to how you might understand disease or might even react to disease. Right? So other cultures might react very differently to disease or might define things in a different way. And so you have to stay open-minded to other people's cultural influences when it comes to their health and disease. Age differences, right? A normal value for a person at one age may not be normal for a person at another age. So age differences, right? They are going to be like blood pressure. Blood pressure is not going to be the same when you're 10 than when you are 90. Okay, so your blood pressure when you're 10 is probably going to be like 90/60. That's actually normal. But when you're 90 and you have a blood pressure of like 135/85, you're probably still without medication, let's say, right? That's probably pretty good for somebody with that many years, right? And that much things that they may have gone through and may have surpassed. Okay, so they consider that a relatively normal number. Same thing with like hemoglobin, right? My mother's 81, and you'll see that I got to talk to her doctor, and her hemoglobin values are like 11.9. For a female, it's usually 12 to 16 milligrams per deciliter of their hemoglobin, but yet hers is 11.9. Doctor's like, I wouldn't worry about it too much, because the older you get, it's going to get a little bit lower. Right? Your body doesn't make as many red blood cells, as much hemoglobin, right? Everything kind of slows down a little bit. It hasn't affected her. She has no signs and symptoms of the disease. So if there's no signs and symptoms, then you don't really worry about it. But that's where asking questions is very important. All right, so gender differences. See, values for men and women may be different. So for example, hematocrit and hemoglobin as well. Hematocrit is going to be different for men and for women, and because men have androgens, right? They make testosterone and dihydrotestosterone, and this actually increases the amount of red blood cells that they have. Okay, so remember, hematocrit is the measurement of red blood cells. It's a percentage. So what percent of your blood is actually red blood cells? For a male, it might be like 42 to 52% normal, but for a female, it might be more like 37 to 47. And so that might be relevant to health and disease. Who is more likely to have anemia, a male or a female? A female is way more likely to have anemia. When a male has anemia, you need to go looking for the cause immediately, because that probably means that they're bleeding out and internally, like their intestines may have ruptured or something like that, because it is a very serious problem when a male is showing anemia. Maybe they stopped making red blood cells. We call that aplastic anemia, right? So situational differences also could be considered, right? So any, derivation from normal should be considered, even time variations also, right? So day-night cycles, right? So I was just talking about this with one of my students, in the morning, our cortisol levels are very high. In the afternoon, they kind of tend to be low. And then in the evening, they tend to peak as well. So you got like, super high energy in the morning and super high energy at night, right? But then during the middle of the day, we're sort of a little sluggish, okay? And then at night, as your cortisol levels goes up, your cortisol levels go down, towards, you know, like 10 p.m. and so on, 9, 10 p.m., you're going to see your cortisol levels dip and then your melatonin levels go high. But what does melatonin do? Melatonin helps you sleep. You'll know that cortisol is your main stress hormone. So your body goes into like a stress situation, so that when you increase cortisol levels, you are basically putting your body in like a state of hyperactivity. Okay, so it's more active. So when the sun comes out, cortisol levels go up. So you'll see a peak at about 7 a.m., 8 a.m. After you wake up, maybe even 9 a.m. You'll see after you wake up. So if you have that where you wake up when you see the sun, that thanks cortisol, you're waking me up, especially on a Saturday. Nobody wants to wake up on a Saturday at 7 a.m. when you don't have class to go to. But you know what? It happens. All right, epidemiology. So epidemiology is super, super awesome. I happen to love epidemiology. So I want you to understand that epidemiology is looking at people not individually, but in populations, right? So you have populations of people, you have, you know, males and females, you have people of certain ethnicities, certain backgrounds. You have to consider them, because a lot of times these different disorders and so on are going to be found right within groups of particular people in particular populations. So we look at the population of like Miami. So how much skin cancer are there in people in Miami? So we want to know that. This is important for us to know, because this, you know, obviously the sun is going to be greater here than, say, you know, in northern, you know, like Boston, right? That it might be lower. Skin cancer might be lower over there, that people are not as exposed to the sun. Right. So then there's a few words we want to look at, right? So the word incidence, right? The word incidence is the new number of diseases, right, in a particular year. Usually is how it's measured. Like the CDC, the Centers for Disease Control, the National Institutes of Health are all going to be, and especially the CDC. So that's basically what they do, is they look at populations, and they're going to tell you things like incidence and prevalence. So incidence is going to be the new number of people that are diagnosed with, let's say, skin cancer, right? Prevalence are the people who already have skin cancer. So prevalence might be, you know, people who are already suffering, but the incidence is going to be usually measured by year, might be measured by month, depending on the situation. So say like the flu is actually measured almost daily, if not weekly, because we need to know if there's a peak in flu. That means that the virus is going around, and we need to do something as public health professionals and people working in the medical field. So there's something we need to do, right? So incidence is new cases of disease, and prevalence are those that already have the disease, right? I want you to think of a bathtub, okay? Fill the bathtub with water, right? In your brain. A faucet. Faucet drips water down into the already halfway full, let's say, bathtub of water. The faucet dripping down water is incidence, and prevalence is the amount of water that's already there. So prevalence, the people who already have disease, and incidence, the people that are coming then into the bathtub, the new people that are now falling into this disease. Okay. Now, there's also two ways of escaping, right? You either get cured, right? So there's a drain, or you die. Okay. So those are the two things that are going to be leaving, right? The people leaving out of the bathtub. All right. So then transmission, right? Distribution of the diseases in large groups. We'll talk a little bit about that, right? So, disease can be endemic. That means that there is a natural amount of the disease in the population. Usually this is regional or local. This is not something that, you know, like it usually is over the state of Florida. It might be Miami-Dade County. And so there's going to be a certain amount of, let's say, flu. There's always people who get the flu, even if it's not flu season. But when it is flu season, all of a sudden the number of cases, instead of being like 2 cases that might be endemic, now all of a sudden it's 200 cases. That's epidemic, right? And then if a particular disease goes from country to country to country, we call it a pandemic. So that's in more than one geographical area, and it starts to spread within that geographical area. All right, so some other factors, right? Age, ethnic group, gender, right? Socioeconomic factors, lifestyle considerations, even geographic location, right? These are factors that affect patterns of disease, right? So which of the following is an example of a factor that would affect the epidemiology of a particular disease, right? So what do you think that is, right? Predictive value? Not exactly. Southeast Asian ethnicity. Okay. Okay, it's very possible. Circadian rhythms? Maybe, but I think that might be a distractor. Clinical manifestations, no. So I think Southeast Asian ethnicity. All right, so then what are our levels or patterns of disease distribution, right? Well, in order for us, and a lot of this has to do with public health, because public health is very closely related to epidemiology, because like epidemiology is like the science and like the statistics behind public health, which has a lot to do with how do we help the people in this population. You know that there's a Center for Disease Control that basically covers the entire country. It is not a regulatory agency; it just monitors what's going on. There is a health department, that's the Miami-Dade County Health Department, that monitors what's going on in this county, right? So then if you find that there is a situation in this county, say that there was an increase in a Zika virus, right? What are you going to do about it? So we're going to need to look at some levels of how we can prevent this from spreading. So primary level of prevention is altering the susceptibility or reducing the exposure for susceptible persons. Okay, so what do? Let's kill the mosquito, right? That's kind of primary prevention. It's going to stop the spread of the Zika virus. Okay. Secondary, well, let's get a rapid Zika test at the different hospitals so that we can detect it as soon as somebody gets it, right? So that we can try to minimize their signs and symptoms if possible. Tertiary, well, a tertiary would be, well, the person already has the disease, so what can we do? Let's provide, you know, supportive care, maybe to try to return their health back to normal as much as possible. So many times hospitals, nursing are working at a tertiary level of prevention. A lot of public health goes into primary and secondary. Some hospitals do work secondary, like they offer mammograms for people with low income and things like that, so they can monitor their health. However, you'll see that the majority of the time as a nurse, you're going to be working with people who are already sick. And so then you're going to be working at that tertiary level of prevention. Which are the following an example of a primary prevention. So maintaining routine immunizations, screening for cancer, rehabilitation after a stroke, performing monthly breast exams. Okay, so screening for cancer and performing monthly breast exams are going to be what type of prevention? If you said secondary, you said, yep, that's true. Okay, so this is, we are trying to catch it early. So everything about secondary prevention is trying to catch it as early as possible. Rehabilitating after a stroke, so rehabilitation or anything trying to return you back to normal is going to be tertiary, right? Again, that's what hospitals are for. People come in, they're sick, and we got to, like, you know, Humpty Dumpty fell down, and we got to glue Humpty Dumpty back together again and then deliver Humpty Dumpty in the form that he came back out into the world. So maintaining routine immunizations is our example of primary prevention. All right, and so this concludes chapter 1, and so I'll go ahead and do a different one for chapter 2. Thank you.